The next speaker is none other than Dr. D. Ramamurthy, past president of AIOS, one of the leading refractive surgeons in the country. He is the chairman of Eye Foundation Coimbatore, and he will be talking to us about are all patients suitable for Contoura Lasik.
So I think this topic is also really important because Contoura Vision has really taken sway, and I know that Dr. Ramamurthy thinks very objectively and can come up with when and when not to choose Contoura for patients.
Thank you, Rishi, for that nice introduction, and thank you so much, Gaurav, for including me in this very nice course. I'm going to give you an overview of Contoura Vision and my indications and where when exactly and what is the data I use for doing Contoura Vision. Basically, this is one treatment which worked in the reverse direction, in the sense that it was initially taken up for doing as a repair tool for defective corneas. It was introduced way back in 2003, and where we used to do customized ablation based upon the topographic examination, so as to regularize an irregular cornea. Basically, this was the principle of the treatment. You can see over here, this is a flat area, this is a steep area. This is the kind of treatment that is done. To the steep area, you directly ablate, and beyond the flat area, you do the ablation. So that with this bimodal treatment, you end up with a fairly regular cornea and a good improvement in the best corrected visual acuity. What we are looking for in these situations is a best corrected visual acuity. For a long time, we were used to wavefront guided ablations. The optics was what was the buzzword when we started out with LASIK. But basically, topo guided treatment seems to make a lot more sense, because wavefront guided ablation basically flattens out the most steeper area. If your cornea is like this is going to treat only over here and flatten it out. But in the case of the topo guided treatment, it's going to flatten out the steep area as well as the steepen the flat area, so that it becomes like this by doing a peripheral treatment beyond the area of flattening. So because of this bimodal treatment, the amount of tissue that is consumed is much less, and you get a much more regular cornea with this. And that's the reason it was being used for topo guided treatment. Another important advantage of a topo guided treatment over a wavefront guided treatment is that the data that you acquire is what you treat. And because the cornea is static, the kind of aberration profile that you get is reproducible. More of the peripheral data can be taken out. Almost 20,000 points are considered. And most of the aberrations in the eye are based upon the anterior corneal surface, and it is not affected by age, pupil size, lens opacity, etc. And again, this takes into consideration the asphericity of the cornea as well as the curvature of the cornea. And most importantly, the treatment is not centered on the pupil, but centered in the visual axis of the corneal vertex. And inherent to this treatment is cyclotorsion compensation and pupil centroid shift, which happens every time the patient shifts from a sitting position to a lying down position. And because of this, obviously, this is a much more physiological treatment to go ahead. So what exactly is the difference between topo guided treatment, what we have been doing for almost 2 decades now, to the recent, not exactly recent, almost a decade now, we have been doing Contoura Vision. Contoura Vision is essentially the principles of topo guided treatment applied on a so-called normal cornea, where basically it's a run-of-the-mill garden variety refractive error. You go ahead and take care of the refractive error. At the same time, you go ahead and take care of whatever corneal aberrations are there, because of which in the initial FDA study, almost 33% of the patients not just had improvement of the quality of vision, but also the quantity of vision. This was one treatment which gave up ending a better uncorrected visual acuity than the best corrected visual acuity that the patient started out with. So this is the original topographic profile of the patient. This is the ideal topography, and this is the ablation profile that needs to be given. You combine it with the refractive data that you get with the subjective refraction, and that is what you apply on the patient's eye to correct the refractive error. As you can see here, this is basically the manifest refraction that's being corrected. This is the height data that my topolaser gives for correction of the higher order aberrations, and this is the final treatment plan that the patient is subjected to. Usually in the central area is about a few microns of tissue that's taken ahead, and in case there is more of higher order aberrations in the peripheral area, there is steepening or flattening, so as to not just take care of the refractive error, but also take care of the higher order aberration. That was just the fellow eye of the same patient. Now comes the question as to what exactly is the data that you are going to use as far as the refractive input is concerned. Mind you, your lasers are all mature. Irrespective of the machine that you are using, the physics of lasers is so advanced that they are exactly going to do what they are meant to do. Basically, what are you going to input in this? Most often, what the TCAT FDA study used was the refractive cylinder axis and the magnitude. And in these were cherry-picked such that the topography of these patients, the cylinder, the axis and the amount of cylinder in these cases almost match what was there in subjective cases. But this is a very ideal situation, and in the usual real world situations, 43% of patients I would not satisfy for these criteria. And practically, these might be the patients who have a significant difference between the refractive astigmatism and topographic astigmatism, who might end up with the principles of a treatment with a Contoura. So basically the debate comes in as to what exactly is the inputs that you are going to give, whether it's going to be a manifest refraction or is it going to be topographic axis as far as the cylinder is concerned, or you go somewhere in between, which is really not a good way to go. There's no science to it. And then, of course, 4 CDs came up from Mark Lobanoff, where he basically gives us numbers to the kind of aberrations that are contributing to astigmatism. We tried all of this. We are initially doing all with the manifest refraction. Then, because Mark, we tried on the TMR. It did not work too well. 4 CDs is something which we did for quite some time. But now we have come back to manifest refraction axis. It's not just our experience, which I'll be alluding to in the end, but this very significant study where nearly 25,000 eyes in Germany were treated, in Canada were treated, in multiple centers. Retrospectively, we are analyzed between July 2018 and July 2019. 14,000 eyes or so had just a small axis of deviation between the topographic axis and the manifest refraction. But almost 2,000 eyes had a very large angle of deviation, that is more than 45 degrees. But irrespective of the mismatch between the two, they went ahead and treated all the eyes based upon what the subjective refraction came up. And what they found was, irrespective of whether there was a small angle of deviation or a very large angle of deviation, almost 45 degrees, the results were comparable. So the conclusion was that basically the treatment should be on manifest refraction, and we need not exclude such of those eyes where there is a significant discrepancy between the measured and the manifest refraction. Basically, there are 2 different types of astigmatism these patients present with. When it's a small angle of deviation, that is between the measured or the refractive cylinder and the topographic cylinder, it's a larger amount of cylinder that's there. It's 1.2 to 1.6 diopters, and 86% of them had with the rule astigmatism, which is what you expect in the younger individuals. So basically, this was genuine corneal astigmatism that you are treating. On the other hand, when you are talking about very large angle of deviation, it was a smaller cylinder, 0.45 to 0.66. And more often, 85% of the patients almost had against the rule astigmatism. So intuitively, this astigmatism that was being picked up on your refraction was not the typical cylindrical astigmatism of refraction, but this is essentially from the posterior surface of the cornea, from the lens and from the interiors of the eye. So basically what we did was to do a contralateral eye study of 100 patients, 200 eyes. One eye underwent wavefront optimized treatment, one eye underwent Contoura treatment. The purpose of this study was essentially to compare the 2 modalities of treatment. But what we found out was 100% of the eyes undergoing Contoura had a post-operative mean residual spherical equivalent of less than 0.5 diopters. It was in the case of wavefront optimized treatment, which is again an excellent treatment, it was 95%. And more importantly, just like in the FDA study, 30% of the eyes undergoing Contoura treatment had a 1-line improvement in that uncorrected visual acuity compared to the preoperative best corrected visual acuity. Again, we found that Contoura induced less amount of horizontal coma and trefoil. And mind you, in this particular study, we included all comers irrespective of the variation between the measured on the topographic axis of astigmatism. So this is the way we are doing. This was also published in the Indian Journal of Ophthalmology, and these are multiple presentations, multiple publications that have come about. I know that Kanelopoulos talks about TMR, Lebanov talks about Phocidis, but to my mind today, having a significant experience with all these different platforms, irrespective of the kind of variation, we go ahead and plug in the refractive cylinder and the refraction, the subjective refraction that our patients come in with, and then add on to it the higher order aberration profile that we get to it a topolizer, and seems to work well. It makes absolute sense to me, because what you correct with your manifest refractive astigmatism is essentially a sum total of anterior corneal astigmatism, posterior corneal astigmatism, internal astigmatism, and what the cortex perceives. Finally, you see with your eyes, but the vision is through the brain. So hence, targeting manifest astigmatism leads to excellent visual outcomes irrespective of the discrepancy in topo and refractive cylinder. So thank you so much for your kind attention.
Thank you so much, sir. It was fantastic as always. We have been also using Phocidis a lot, and I think we've had amazing results with using Phocidis. Has kind of sorted it out for us much better than we did last few years. I wanted to just ask you that, considering that you also have access to almost all modalities of refractive surgery in your setups, and where would you really want to sacrifice the strength of a PRK or a SMILE for biomechanical stability for LASIK, Contoura based LASIK treatment? Like, which are those specific cases? You've already covered all that, but if I had to ask you in like one line or two lines, that where would you really pick, sacrificing the cap or the surface for a flap and the lower biomechanicals, because that would be where, it would really be useful. I know it works well for everyone, but since you have access to two other things, what would you choose?
See, PRK I feel is the biomechanically the most friendly treatment. So whenever there is the slightest doubt about the corneal strength, biomechanics, we tend to shift towards PRK. And then SMILE is our primary modality of treatment, but still all of us know that there is no cyclotorsion compensation on this. And whenever there is a significant amount of cylinder that I have to go ahead and treat, beyond 1.5 diopters or 2 diopters, I go ahead and do a Contoura vision. And in case the patient is very particular, supposing the patient has a fair amount of higher order aberrations, the best corrected visual acuity is in the range of 6 parts or so, I go ahead and again tend to tilt towards Contoura vision. We do a higher order aberration assessment in all these cases. Where it is significant, we go ahead and do this. And mind you, these are the situations where you would find that your refractive cylinder and your topographic cylinder do not line up. But these are the patients who really benefit from this particular treatment.
I completely agree, and I think you've summed it up really well. Thank you so much, sir. Please, would you join us here? And I'll now introduce our next speaker, Dr. Rishi Swaroop, who's a dear friend, a brilliant cornea surgeon, and does amazing refractive surgery as well. And he's taken on from Hyderabad, and he's taken on a topic which again is very, very important, doing the extra procedures. With all his experience from Shankar Netralaya and LVP, I think he will be best suited to speak here. Yes, Dr. Subhash?
Recommendation was that if the axis is more than 15 degree, then you go for the wave front optimize and don't go for that Contoura. So now you are doing Contoura for all.
That's exactly the perception, in the sense that, in the FDA TCAT study, that was basically the basis of, they cherry pick such cases where the topography and the manifest refraction almost matched. Maybe these are the cases which did not require Contoura in the first place. Because the reason they matched absolutely was the simple reason that there was not much of higher order aberrations. With a significant amount of internal aberrations, posterior corneal astigmatism, that is when it is not going to match. So you have to take a leap of faith and go ahead and treat these cases based upon your subjective refraction and combine with your higher order aberrations. There was a whole lot of discussion on which one to use, and I find that for the last 3 or 4 years we have been doing this, and this very large study also shows that if you do that, it works quite well.